but a Likert of 1 is almost 10, and the MVP in the second is 1.96. Here's another example where again we have sFGR, but the Likert of 1 is 14, and the Likert of the second is 1.6. So moment you see that there's a gross Likert discrepancy, typically when you have figures going below 2 or going above 8 or above 10, then your diagnosis should be TTTS, and you should now label this as a TTTS and basically also manage it as a TTTS rather than as an sFGR. This is very, very important. The third thing which we now need to also do is diagnose or exclude a coexistent TAPS. For that, of course, we are going to look at the middle cerebral artery Doppler, and we also know that fetal anemia in a monochorionic twin can also come up because of other causes. So we need to keep a watch on that. So this chart basically helps us in differentiating TTTS, TAPS, and sFGR. Of course, there are going to be overlaps. So when you have a gross fluid discrepancy, it is more likely to be TTTS, though you might get it in sFGR, but not as much as in TTTS. If there is a gross growth discordancy and it fulfills the definitions which we have talked about, then we are more likely to be dealing with sFGR. Of course, in TTTS, we can have growth discrepancy. If the mediastinal artery shows a high PSV, then we are dealing with TAPS, but this can happen in both these situations. If there is a fetal bladder discordancy or if there is a fetal hydrops, then again, we are more likely to be dealing with a TTTS. If there is a ductus venous abnormality in the recipient twin, then again, we are dealing with TTTS. And if the placenta on the donor side is hyperechoic, is fetal, then again, we are more likely to be dealing with TAPS. So this basically helps us in differentiating these conditions. There are overlaps, but as far as management is concerned, in our mind, we need to be very clear what we are dealing with, and I think this helps us in day-to-day practice. The fourth thing which you need to now do is look at a cardiac function. This is for two reasons. One is if you see a deteriorating cardiac fetus, especially in type 2, type 3, and then you can predict that there's a potential IUFD happening and you can do something about it. So cardiac function helps us in prognosticating as well as taking management opinions. So this can be done either by looking at the myocardial performance index, or if you have newer techniques like the strain imaging or rectal imaging or whatever you want to call it, you can use one of these techniques also. So now we have done three things. We have diagnosed sFGR, we have looked at the type based on the umbilical artery Doppler of the smaller fetus, and we have done 4 additional steps. The 4 steps being looking out for anomalies, discordant karyotyping, ruling out associated TAPS, ruling out associated TTTS, and then of course, lastly, looking at the cardiac function. So with all these things at the back of our mind, now we have to think of management. Now the primary goal of managing pregnancies in sFGR is to identify those that can be safely managed conservatively versus those which benefit from fetal intervention. So this differentiation is very, very important. And this will be based on several factors, including gestational age, prognosis, of course, technical considerations, prognostic factors, some technical considerations, and of course, the patient preferences. Now, whenever we want to take some decisions, we turn towards guidelines. And unfortunately, when you look at guidelines for sFGR, the ISWAC guidelines state that there is limited evidence to guide the management of monochorionic twins affected by sFGR. And the RCOG says that due to lack of available high-quality evidence, there is no clear guidance on how to manage sFGR in twin pregnancies. So our guidelines are not going to help us, and therefore we need to be very clear in our thoughts how to manage these pregnancies. There are some negative prognostic factors. That means some things, if you see, they are not very good, and this is very important from the point of view of explaining to the parents. If you have a very early diagnosis of sFGR, if there is a very high degree of intermittent discordancy, typically going above 35%, if there's a prominent intermittent reversal of flow in the smaller fetus, and there's a short distance between the placental cord insertions, these are considered as negative factors. Now, it is very important to do a proper follow-up, and as compared to follow-up, which we normally do in 2 weeks for every monochorionic pregnancy, once you are diagnosed in sFGR, then we need to do a follow-up every weekly. And the idea is to stretch things as much as possible till we attain the age of viability, but avoid a single intrauterine death, because as we'll see subsequently, a single uterine death has serious consequences on the surviving protein. So when we go ahead, we might take help of other parameters like the ductus venosus. We might take help of biophysical profile if you have got a computerized cardiotography, that is also useful. But basically, close monitoring is very, very important. But we don't wait till the end when the ductus becomes grossly abnormal. We need to interfere or deliver even before that. Very often, you have reached a good age, you might give steroids. Remember that very often after giving steroids, the umbilical artery flow may improve transiently for some time. There are some very important points to consider ourselves, as well as when we counsel the patient for management. There are some important points which we need to consider. First, we have to explain that there is always an incidence of severe cerebral injury in monochorionic twins complicated by sFGR, which can be as much as 10%. And this is more commonly seen when there's an abnormal umbilical artery Doppler grossly, single IUD, or a low gestational age at birth. We should also explain that there is always a neonatal morbidity, particularly respiratory distress syndrome and cerebral disease, and these are more commonly seen in the larger fetus. We should also keep in mind and explain to the parents that if one of the monochorionic twin dies in utero, the surviving twin may lose a part of its circulating volume to the dead twin, giving rise to severe hypertension in the survival. This can give rise to hypoperfusion of vital organs like the brain, intestine, etc., and that can cause brain damage and death. This is very, very important to be kept in mind. So how do we go about it? Typically, in type 1 sFGR, what we need to do is a weekly Doppler, and beginning from 28 weeks to 28 weeks definitely. If everything is stable and reassuring, then we try and stretch them to 34 weeks or 35 weeks. That will be good enough. But if there is a progression, that means the Doppler indices are showing more increased resistance, or the MCA is showing abnormality, then we need to increase our surveillance to twice a day, add ductus venosus, and again try and deliver them at an appropriate gestational age. Guys, example of type 1 is sFGR, where there is a diastolic flow, and as you can see, we have stretched them to 34 weeks of gestation, and we had to deliver them at 34 weeks, and they are doing very well. In type 2 sFGR, the approach, especially to the moderate and severe sFGR, is more complicated because of the higher rates of adverse outcome, particularly fetal demise. And we have to remember, as I said earlier, that demise of one twin can result in acute fetal transfusion volume shifts, which leads to double fetal demise or neurological damage in the surviving protein in as much as 25 to 30%. So when you're following it up, and especially with Doppler, and you feel, or when you're looking at cardiac function, that there is a very high chance of a fetal demise in one of the twin before 26 weeks of gestation, then we should think of an option of selective termination, so that we protect the normal fetus from the harmful effects of the death of the smaller fetus. So what do we do in type 2 and type 3 sFGR? Again, weekly Doppler. If everything is stable, everything is reassuring, try to push them to 32 weeks or 34 weeks. However, if there is a progression, and by progression I mean worsening of Doppler, change of type from, say, type 2 to type 3, ductus venosus becoming abnormal, oligohydramnios becoming more and more in the smaller fetus, then we need to think. If the fetus is already closer to viable age, maybe what we can still do is increase our surveillance and try and deliver whenever appropriate. However, if the fetus is in a pre-viable age, typically like for example 26, 24 weeks, etc., then we need to think of selective fetal reduction. If this is accepted by the parents and you are able to do this, of course you're going to lose one fetus and then we can manage it as a single pregnancy, but we need to keep a watch on this fetus also. If we are not able to do reduction, or if the parents are not wishing to do it, or the law prohibits us from terminating at that particular gestation age, then we can think of a laser ablation. If this is done, there is a risk of the demise of the smaller twins, and we will see why, of course. And then, then you can manage it as a single pregnancy, and if both the twins survive, then we manage it as a diconic twins because you have done it. So this is just a rough outline of how we can manage, but each case is going to be individualized depending on so many factors, including what we are seeing the parents' wish, and your own skill and ability to do things. So I'll share some of our cases which we have done. So this is a type 2 sFGR. We saw it at 20 weeks of gestation. The discordancy, as you can see, is already gross, about 35%. The umbilical show an absent diastolic flow. So we counseled the patient, and by the time we counseled and they accepted, it was already close to 22 weeks of gestation, and we did a cord coagulation. So that's a bipolar cautery cord coagulation. In this particular case, this was one of our initial cases. Prashant had come and helped us in this case. So bipolar cord coagulation is relatively a very good technique for selective reduction in an sFGR. However, the technique is maybe slightly difficult, especially holding the cord. Though it looks very easy, very often it's not easy because the cord slips. But it's a the cord coagulation happens very fast. You can see the as it coagulates, you can see the bubbles coming, and you can see the result very instantaneously. And in this pregnancy, everything went on fine. We kept a close watch on the surviving twin, and she delivered at around 33 weeks of gestation, quite premature, but the baby has done very, very well. Another example of a cord coagulation being done on sFGR, and as you can see that sometimes it is not a very easy technique. And as I said, the focus of this talk is not the technique of all these procedures. The focus is to make everyone aware of this entity and pick up things at the right time. This again, we had a very favorable outcome. This is another type 3 sFGR. You can see intermittent reversal of flow. And this is again very, very early. So in this particular fetus, and radio frequency ablation was done as a mode of terminating the smaller one. Now, RFA technically is much easier, especially for radiologists, because we have been doing RFA ablations for liver tumors for quite some time. Some of us do it for kidney tumors, bone tumors, etc. Though it's a costly technique because the RFA needle is quite costly. Technically, it is easier, but because even the size of the needle is really smaller, it is just about 17 gauge. But the problem is that sometimes it takes time for the procedure. Sometimes you have to repeat the procedure, and the results may not be seen very immediately. So these are the drawbacks, but technically it is much, much easier as compared to bipolar cautery. So this again, fetus we followed up 23 weeks, we followed it up almost every 1 week because we wanted to be sure that everything goes well. We looked out for any neurological damage in the surviving fetus. We kept a watch on the NC Doppler. Again, we delivered at around 33 weeks of gestation. The baby has done very, very well. Fetoscopic laser is very difficult in sFGR. This is because there is no polyhydramnios, the equator is in smaller sac, and of course the type and size of anastomosis is laser done by Suresh, Dr. Suresh, in one of our cases many years back. I don't do lasers myself. This particular fetus, I remember that after the laser ablation also, we had a tough time. There was taps which happened. We had to take care of that. We had to keep a very close watch. But ultimately, we did get good results. And as I said, technically, this can be difficult. So, what to do? So, basically, do we leave it alone, sFGRs? Do we do intervention? If we do intervention, should we be doing selective reduction with one of the techniques, maybe bipolar cautery or the RFA showed, or should we think of doing the laser ablation? So, for many years, we had different opinions coming from different people. Some prefer this, some prefer that, different results. Even in India, amongst our close colleagues, there are differences. But last year, in 2019, this was an article published by Townsend, and this is basically perinatal outcome of monochorionic twins complicated by sFGR. According to management, it's a systemic review and meta-analysis. They have taken 16 studies, and this is a study of almost about 800 monochorionic twins. And the next few slides, which I'm going to show, is basically I'm going to quote this article. So basically, as far as type 1 sFGR is concerned, they have a good perinatal outcome when managed expectantly, which represents the most reasonable choice for management. In type 2, type 3 sFGR, which are treated with laser therapy or SA or a selective reduction, there's a higher rate of perinatal mortality, but a lower rate of morbidity compared with those managed expectantly. So with laser management, we know that there is an associated higher incidence of fetal loss but all survivors were free from neurological morbidity and follow-up. And this is very encouraging. And this, of course, reduction in neurological morbidity is because you have made a placenta into a type 1. And here, there is a very high chance of losing the smaller fetus because the advantage which the smaller fetus had because of anastomosis is lost. So basically, once you have done a dicoagulation, the fetus which was getting its aid from the larger fetus, this aid is stopped and you can land up with an IUD. So this we have to keep in mind. This article somewhere along the line says, or it inclines towards selective reduction, though it doesn't say it in those words. And typically it says that this would be preferred if you are feeling the death of one of the fetus, because technically it is easier as compared to laser ablation. So let's see the outcomes in this particular study. In type 1 FGR, with an expected management, the intact survival is very good, almost 98%, which is very good, and we would all like to have that. In type 2, with an expected management, the survival without neurological compromise gets down to almost 89%. With laser, there is a very high incidence of IUD of the polar twin. But what is encouraging is that none of the affected or basically after birth, there was no neurological complications. And with selective reduction, of course, there was a risk of an IUD of the core twin also. With selective reduction, one fetus is already going to go, but in 5% they lost the other one also. But what is very encouraging is that the surviving core twin was free from neurological complications in 90%. In type 3, with an expected management, the intact survival dropped to only 60%. With laser, there was an IUD of the other fetus in fetus in 32%, but all surviving twins were without neurological complications, and in selective reduction, the intact survival was 98%. So this gives you a rough idea about how things go with wait and watch management or with interference. So at the end of this particular study, they say that there is little robust evidence of optimal management. So as of today, we don't know what is right and what is wrong. But type 1 has good parental outcome and expected management is appropriate for most of the cases. Type 2, type 3 are affected by a higher burden of parental mortality and morbidity. And fetal therapy may have a role at pre-viable gestational age in severe cases in order to protect the surviving twin from demise or neurological damage. Though they also say that as of today, they don't directly support therapies like laser or SR. So we have to take everything in the right perspective. But basically, this paper is helping us to take management decisions as well as counseling the patients. What is very important is to keep a close watch on the surviving twin in case there is an IUD of one fetus continuously or there is an iatrogenic IUD after a selective reduction. There can be a death of core twin in 15% preterm delivery, abnormal postnatal cranial imaging, and neurodevelopmental impairment of the surviving twin in almost 25%. So we need to keep a close watch on the surviving fetus in terms of the cranium, in terms of the NC Doppler. Very often we might even ask for an MRI in between and give us an idea about the fetal damage and proper surveillance. So to conclude, as I said earlier, the idea of this talk was not to talk more of technicality, that's a different topic, but to create an awareness amongst people who do ultrasound day-to-day practice. We should pick it up at right stage, diagnose it correctly, do the umbilical artery Doppler with the correct technique and come to the right type. Follow those 4 steps which I told you. Overall, type 1 has good prognosis. When you see an early onset type 2 or type 3, just to be careful. Monitoring is very important in all sFGRs, whether it's type 1, type 2, type 3, and monitoring has to be done weekly and if required even bi-weekly because it's very, very important. And in early onset type 2, type 3 with severe sFGRs, there is a potential role for active management, and we discussed that also. But ultimately, the decision is a balance between the severity of the disease, what you're seeing, the follow-ups, the parents' wishes, and your own technical skill. What is very important is do not hesitate to refer the patient to a specialized center or take an opinion from anyone who is skilled. And at least all of us, in fact, talk with each other very often on the phone. I have no hesitation in calling up Suresh, Prashant, Pratima, or any one of them, or those who are doing more work in intervention and discussing that. It's very, very important. And gradually one can learn the skills. They are not very difficult, but one can learn them. And of course, careful monitoring of the surviving pain is again very, very important. So thank you very much.